patient assessment, and nobody reminded me to record the session, but I just did anyway. All right, so there's millions and millions and millions of scenarios out there that we could explore, but we're not going to do that tonight. We'll talk about every type of situation, any type of injury, any type of medical situation. You're always going to get the what if, what if, what if. Well, there's no way that you can answer all the what ifs, because for every what if answer I give you, you could probably give me another 10 what ifs based off that. And each and every patient is different. Each and every emergency is different. However, the approach to your patient, whether it be medical or trauma, is really standard. And to give you a point, let's just look at this little scenario right here. If anybody's familiar with the Bronx, you respond to the corner of 3rd Avenue and East Fordham Road. Girl who's been struck by a vehicle. There's a large crowd on the scene and one police officer attending to the child. You find the child lying supine in a pool of blood, crying hysterically. Upon further examination, you find the child's leg is partially amputated. Quickly, what would you do? What would you do? Somebody answer me, quick. Oh, not fast enough. This kid's bleeding out. Okay. Okay. Junsung will put it in tourniquet. Okay. Anybody else? Wow, time's ticking away. Time. Were you just staring at it, freezing, chewing your fingernails, chewing your toenails? What are you doing? Okay, Jazira's going to start singing A, B, C, D. I have no idea what that means. Amelia, how? Stop the bleeding, stop the blood. Is that your priority? Is that the first thing you want to do? The second thing you want to do? Okay. Call a cab? I don't know. What do you want to do? Okay, well, let's stop for a moment, because luckily this is a classroom and this is not the real scene. But this is actually a call that that I was on many years ago in the Bronx. What had happened was, it was the, I don't know, it was on Fordham Avenue and Fordham Road and 3rd Avenue. There was a Sears shopping center, and what had happened is somebody who was going shopping left their toddler in the back seat of their car with the car running. The toddler was about 2.5 maybe. And then she left the car to go retain some more packages. Well, just as she had left the car, and I can tell you honestly, yes, this will happen, and it can happen. The toddler somehow worked his way out of the car seat, climbed into the front of the car, was able to move this gear shift from park to reverse, and put his weight down on the gas pedal. And just as he did that, the car peeled out, and just as the car was peeling out, another family walked by in the parking lot with a little 6-year-old girl who had traipsed a little bit in front of the family, right in the way, and she was mowed over. And yes, there was a big crowd on the scene. There was a hysterical family member on the scene. There was a police officer on the scene. So we got on the scene. There was BLS backing us up, and yes, there was a nasty, nasty wound to the lower extremity. We took care of it. We bandaged her up. We assessed the airway, breathing circulations, like somebody alluded to. We transported her appropriately to the pediatric trauma center. At that point, there was other police on the scene. The police officer was visibly upset about this situation. He was upset that he felt he had not done enough. I think he had a little child of his own about the same age who, he got identified with. He didn't know what to do. He didn't know what to do about that leg. He didn't know what to do about that blood. He didn't know what to do about that child, that 6-year-old screaming hysterically. But you know what? That's okay, because that police officer wasn't supposed to know about what to do about all that. It wasn't his job to know that. He did his job. He called in the job. He kept the scene secure. He rode with the child. He took the report. He did everything a good police officer is supposed to do. It wasn't his job to tend to that injury in a logical, methodical, and prioritized manner. It is your job, and it will be your job. And it's not the time where you can just sit around and open up a manual or go on your smartphone and think, oh, what do I do next? It's got to come natural. It's got to come without thinking. And that's going to come by practicing and training, and more practicing and training. Let's dissect this a little bit now. I really thought for the life of me this girl was going to lose her leg, but miraculously she didn't. The orthopedics and the trauma team at Jacobi worked miracles, and they saved it. But let's start off by the response to the corner of 3rd Ave, East Fordham. We know what the call type is, pedestrian struck in a parking lot. First of all, we got to make sure that we don't put ourselves in any danger. And what are some obvious hazards that we got to think about? We got to think about crowd condition. We got to think about, did anybody mention making sure that the car wasn't still on or on fire or anything like that? Did anybody mention making sure we don't expose ourselves to the child's blood? Because honestly, it's safe to say, we don't know what they're carrying. How many patients were there, by the way, do you think? Is it just this one child who was run over? What about the kid in the car? Okay, Marilyn says 2. That's a good answer. What about the hysterical mother on the scene going crazy? You don't think she might have been a patient as well? Yeah, you better believe it. All right, so you got to think about that. You got to think about how you're going to address this injury. This child is crying. She's screaming at the top of her lungs. You think that's a good thing or a bad thing? Amelia, you say good thing that this child is screaming? Explain yourself.
Can you hear me?
Yes.
Yeah, I think it's a good thing that she's screaming because at least you know that her mental status is there. You know that she's breathing. You know that she's alert. So to me, I mean, I would hate to see her scream, but seeing her scream makes me know that other things are still okay, if that makes sense.
So what you're getting at is a very, very important part of what we're going to be talking about tonight. And it's very important that this class understand that you are 100% right.
Oh, thank you.
Don't thank me.
I'm like, yay.
Is that the fact? I mean, it's kind of a little bit of a trick question. Of course, you don't want to ever see a child screaming and crying in pain, especially if you have kids of your own. But exactly what she's saying. You have this major fear, this major trauma you're approaching. Take a breath, size it all in. What do you know just by seeing the fact that this girl is crying hysterically? 1, you know she is alive. 2, you know that her airway is open. You know that she's breathing, and you know her heart is working. You know that her brain is working. So right then and there, you know a ton of information that's important to know that you might not know or you might not be able to get at if she was lying there unresponsive. Now, you also see this grotesque injury, a pool of blood, but again, just because you see a mangled extremity and a lot of blood, is that necessarily the first thing that's going to kill the patient? Maybe, maybe not. A pool of blood that's not spurting is less likely to kill somebody quicker than a tongue that's collapsed in the back of the throat because they're unresponsive and a compromised airway. Now, every situation is different, but again, the approach has to remain the same. Very standard, very methodical, giving priority to the most important things, airway, breathing, circulation, and then putting your attention to the less important things, but doing it in a methodical manner. So the first component of what we're talking about in doing a full patient assessment is called your scene size up. Scene size up really has nothing to do with the patient themselves. It really has to do with you. It has to deal with you keeping yourself safe, you keeping yourself out of the emergency room as a patient, you keeping yourself out of rehab facilities from secondary complications of exposure to the scene, you taking care of everything that you need to get that job accomplished. And certain elements of the scene size up include checking the scene for safety. And really, that's a broad aspect. I have such a problem with some of these lame-ass EMT schools that train their students to recite scene safety, scene safety, scene safety, and not give them any idea what scene safety really entails. About 5 years ago already, wow. 5 years ago? 4 years ago, I'm sorry. 4 years ago at this time, trying to draw a blank. It was 4 years ago at this time, a little bit, March 17th, where an EMT in the Bronx, Idira Arroyo, was brutally run over by her own ambulance by some intoxicated, drugged out hood who was running from the scene of a crime. And it was a horrible situation that really should never have occurred. Don't make yourself that victim. She left behind 5 children, unfortunately. Nobody's life is more important than yours. So you got to think more of just talking scene safety. You've got to live it, breathe it, embrace it. Every scenario that you're approaching, you've got to try to think of anything that could compromise your safety and what you can do to fix it, if it can be fixed. All right, and we'll talk about some of situations as we go through this lesson. Taking your standard precautions, appropriate body substance isolation or personal protective equipment. Does that mean you put a hazmat suit and self-contained breathing apparatus on for every single patient that you come into contact with? Well, with the exception of what we're going through with the coronavirus situation, that's a little bit of an unfair question, but the answer is no. We talked a little bit about appropriate PPE. But anytime you're making contact with a patient, at the minimum, you should have on gloves, because you never know where any body fluid. You're going to have to put your hands on this patient, and you don't know what kind of body fluids are spewing where, and goggles, at the very least. Prior to coronavirus situation, we probably wouldn't have recommended N95 or high particular respirator mask for every patient, but obviously the situation is a little bit different now. But you got to look at every single situation. You get people's faces, so yeah, HEPA mask is appropriate these days. Is level 1 turnout coat appropriate for a minor medical emergency? Maybe not. Every situation is different. You need to take note of the mechanism of injury or the forces that were involved to cause this person to become injured, or the nature of the patient's illness. Is it a cardiac, respiratory, seizure type call? And think about what type of resources you need to aid you in that situation. And also don't discount the number of patients, which goes hand in hand with the question I asked from that previous scenario. It's very easy to focus in on that one patient that all the trauma's going to, but again, there was also a patient in the other car, that little toddler that was rolling around in an unsecured vehicle. There's a hysterical mother who may need, some type of psychological services, seeing her little child mauled down by a motor vehicle. That's traumatic in itself. You don't know what kind of medical conditions this mother might have had that could have been exacerbated by witnessing that. So it's all things that have to be addressed. You guys scared yet? Don't be scared. Ew. At least Marilyn's honest. All right, so let's take a look at this picture right here. It's okay to be scared, by the way. Melody, Marilyn, it's okay to be scared. There's still calls I go on where I get scared. It's okay to be scared. It's not okay to panic. There's a big difference. You can use fear to give you energy, to help boost you to do the right thing, to get your adrenaline level up. It's not okay to panic. When you panic, that's when you screw up. That's when you freeze. That's when you make mistakes. And panicking comes from insecurity. Insecurity comes from lack of preparation. So you prepare, you train, you study, and you retrain and restudy throughout your career. And you make yourself better each and every time. So let's look at this picture right here. Can anybody identify any potential hazards that could endanger the safety and the well-being of the EMT? Okay, yeah, there's a downed power wire for one thing. Or everybody, what else? I see a lot of things going on here. Okay, first of all, it's a rainy, foggy highway outdoor situation. So any motor vehicle accident, regardless of how benign it looks like, automatically presents potential hazards to the EMT. What's the EMT wearing? Nice dark blue coat and pants. Kind of almost looks like a cop. If it gets a little darker, is this EMT going to be seen very well? What should he be wearing? No, he should be wearing exactly a reflective vest, probably better off some turnout gear with reflective stripes on it, a helmet, goggles, all right? I've been guilty of this myself, but you know, over time we learn. How many patients do we have? I really can't answer that question. I see two people on the outside of the car. I mean, that was more rhetorical than anything else. Well, I see two, it looks like I see two people in the car. I'm not sure if I can make it out. I see one person definitely in the passenger seat. Is there somebody in the driver's seat? It's kind of hard to tell. I think so. The person grabbing the doorknob is about to be a patient, and he's about to be a candidate for the morgue, if you know what I mean. Because who out of all the people there, who's in the safest situation? It's the people who are already in the car. They're protected from that down power. The EMT, no, the EMT's in a, you know, he's walking out into by a down power line. He's not protected. If he goes anywhere near that car, if he touches that car, he's likely to become electrocuted. Johnson, I like the way you think. So yeah, so there's a lot of hazards here. Okay, fog, weather conditions, the fact that the car, what caused the car to crash into that pole itself? Doesn't look like there's much damage to the car, but did this person have a heart attack or a seizure while driving? What do we do about that down power line? Well, you know what? We don't go anywhere near that car until the appropriate rescue resources are on the scene and shut the power off on that line. I'm sorry, but nobody's life is more important than my own. You got to think about responding to situations with hazardous materials. We're going to have a whole lecture on hazardous materials awareness, and that's also part of those really nasty, boring FEMA courses that you got to take by the end of the semester. Unstable roads, road conditions. There was a situation, I think it was about 10 years ago in Jersey City on Christmas Day, unfortunately, where two Jersey City police officers were killed when their car went off a bridge that was raised. And it was and something went wrong with the signaling, and it was such a foggy day or a foggy evening they couldn't even see. So they just basically drove right off the bridge. That's a horrible situation. We just got to look at crime scenes and potential for violence, especially these days with these turbulent political situations that are always occurring. It's okay to step back, to stay a safe distance, and let the professionals, the law enforcement, even the military, take over until that scene is secure. And then you can do your job. You got to also be on the lookout for violent, vicious animals, okay, like this carnivorous man-eating pug that you see here. You may think he looks cute and cuddly, but this is a vicious mammal that, if provoked, will attack you. And Maryland, he will kill you. Do you believe that? Yeah, you should. Okay, yeah, maybe not. Yeah, well, he's gone now, but he was spud. But you know what? I make a joke about this, but as cute and cuddly as this little jackass is, I'll tell you one thing. When I was recovering from surgery years ago and laid up on the couch and all bandaged up and everything, and this dog would not leave my side. And when I was trying to unravel some get well balloons sent to me by my family, he was the smartest dog in the world, and he thought the balloons were attacking me, and he started tearing the balloons apart. And then watching TV, there was a scene where a Rottweiler was barking into the dogs, and he runs up and he starts barking at the two-dimensional Rottweiler. Again, sweet, loyal dog, wasn't very smart, but that's what happens with pets. You put a blood pressure cuff on their owner. You try to take their pulse. They don't know what you're doing. They know that you're a stranger and you're putting a hand on their master. And some animals will nip and bite at you, and you don't need that. So you go into the scene where there's an animal, cat, dog, man, please put the dog behind a closed door. Refuse to go into that apartment until that animal is secured. Don't care. Oh, but he doesn't bite. Not that you know of. Again. And I'm a dog lover. I mean, I'm an animal lover too, but at the same time, I love my own health and safety to begin with. You always got to concern yourself about the threat of violence. If there's loud voices, if there's a scene of an altercation, like that scenario we spoke of in the discussion question, keep your distance until law enforcement gets on the scene. If something starts to escalate while you're on the scene, get the hell out. Always leave a clear path between you and the exit route of whatever premise you're in. Okay, nothing should be blocking your way back to the ambulance if it's outside. If you're inside a resident, do never let the patient or family member come between you and the exit. And to kind of yell at one of my EMT backups, not really yell at her, I'm not that mean, but we got to the scene of an overdose victim. She's upstairs in her bedroom, and she's a little belligerent. Uh, EMTs are first on the scene. I'm coming a little bit later as an ALS backup. And I'm opening the door, and she's all the way on the other side of the bedroom, away from the door, between the patient, her boyfriend, and that's it. We had to have a real talking to afterwards. Always make sure that you're close to the exit while you're evaluating that patient. And don't forget your appropriate standard precautions, whether it be just face gown, face mask, gloves, N95. I had a call years ago, gunshot wounds to a victim on the corner of Persona and 183, and this guy was a big 6'5", close to 300-pound dude. Shot multiple times, but got one right in the neck, and he's flailing around. He's alive. He's flailing around on the corner. Everywhere he's flailing, a stream of blood is like spurting like a fountain right around. We were not going anywhere near this guy until we got in the back of the ambulance, packed up our gear, and gowned up, and we're ready to treat him. Yeah, the cops are screaming like crazy, but again, not bringing anything home to our family. Make sure that you have appropriate bunker protective gear. That's me, by the way. That was a really, really cold day, by the way. I think it was like 17 degrees and icy on a standby for a fire. Instructor was not happy. Yeah, well, until it's extreme cold weather gear is really not very functional when it's icy and wet and damp and cold out as well. Yeah, you'll know all about that in time. Don't worry. So anyway, you did got to determine what happened. Is it an injury? So pretty much any job can fall into two categories. It's either a trauma or medical. Somebody's either a victim of an injury or a victim of an illness. And then you can subdivide it from there. Okay, as far as injuries go, is it what's called a significant mechanism of injury, where there are enough forces to potentially kill that person, like a whole fall from 20 feet, a penetrating wound to the trunk or proximal extremities, a blunt object to the head, things of that sort, multiple lung bone fractures? I'm just naming a few mechanisms. Or is it a non-significant mechanism of injury? Something like a sprained ankle or a small laceration, something that just needs to be focused in that. If they're having a medical issue, it's a cardiac or a respiratory, simple. Are they responsive or unresponsive? If they're responsive, then most of the information that you're going to get just by talking to that individual, getting a history. Then you'll go over that a little bit more on Wednesday. Doing a little bit of detective work. If they're unresponsive, then most of the information you're going to get is going to be done by doing a really good head-to-toe physical exam. So let's look a little bit about the mechanism of injury. So understand the forces that cause the injury. For motor vehicles, for example, was it a front impact collision? Which is really not as devastating as it was once 40 years ago, because most cars these days are built with very well protected means airbags, crumple zones, collapsible bumpers, things of that sort. So frontal impact collisions are not as bad as they once were, but you got to think of some of the injury patterns that occur with front impact collisions. Remember, whenever there's a motor vehicle collision, there's actually 3 collisions that occur. Okay? First is the car hitting whatever it's hitting, whether it's a tree, telephone pole, bridge abutment. So that's your first collision right there. The car is going from 60 miles per hour to boom, 0, out of nowhere. Laws of physics, body in motion tends to stay in motion. So where does the second collision occur? The second collision occurs when the body, the driver or the passenger, who is going from 60 miles per hour in the car, suddenly stops. And what suddenly stops the driver is either the steering wheel, the airbag, the belt, the windshield, or it could be the tree themselves if they've been ejected from the vehicle. Third collision occurs when the organs inside the body are suddenly decelerated. So the car stops, boom. The body stops, boom. The brain smacks against the skull, boom. The liver smacks up against the rib cage, boom. The aorta gets torn from its root, boom. So these are all injuries that may not be readily appreciated unless you appreciate the mechanism of injury. Now, in a front impact motor vehicle, person can either sustain what's called an up and over type injury pattern, where they go over the steering wheel and hit their head on the windshield and sustain maybe some trauma to their thighs on the steering wheel, or they can go down and under, where they're cruising like Joe Cool with their one hand on the steering wheel, and slump backwards, and all of a sudden they come to a stop and their body goes under the dashboard, usually breaking their ankles on the pedals and the clutch. If anybody knows how to drive a clutch anymore, I really miss that. Sometimes banging their knee into the steering wheel can cause a posterior hip dislocation, which again you'll talk about when we talk about musculoskeletal injuries. So it's really kind of important to understand the mechanisms involved. Side impact collisions are usually even more serious because you have a lot less protection and more potential for intrusion into the car. So side impact injuries usually there's not a lot of as much protection, causes the body to become displaced from the head, causing severe spinal trauma. Rear impact injuries can cause whiplash type cervical spine trauma, especially if we don't actually see it coming. People don't have a chance to brace themselves for the injury. Rollover injuries are very unpredictable, because especially if the patient is not restrained, in which case you have to pretty much be prepared for almost anything. So we talked a little bit about mechanism of injury. It's very important that you go back to your textbook, go back to your slides, and look at the whole list. We're not going to cover them, point by point here. What's considered a severe or a significant mechanism of injury, and what's not necessarily a significant mechanism of injury. So an adult, a fall more than 20 feet, child more than 10 feet. But you also got to take into account different things. If an adult falls only 10 feet, but they're on blood-thinning medications, or they're elderly, that could be just as significant. And small children, really small children, fall from any significant height. What usually hits the floor first? What hits the ground first? It's their heads, because children are generally top-heavy. Anybody who's old enough to remember what lawn darts are? These little weapons that people used to throw around in their backyard, these like weighted darts that you become deadly projectiles. What happens? Children are top heavy, so they fall, their body rotates, and the head hits first. So when you're talking about falls, some of the most important things to look into are the height from which the patient fell, 2 stories, 3 stories, 10 stories, the surface that the patient fell onto. Would they fall onto direct pavement? Did they fall onto some shrubs and then the pavement? Did they fall onto the grass? Did anything partially break their fall, like an awning? Part of the patient that hit the ground first, which in children we know is anything that from the head up. And just because they land on their feet doesn't mean they didn't sustain any type of spinal trauma, because forces can be transmitted. And also now, you got to look at the nature of the illness as well. Now, it looks like you got a patient who's got more of an injury than an illness, but maybe not. You can't really appreciate what's going on in a two-dimensional photo, can you? You got a young lady, appears to be a young lady, holding her arm. So what happened to her? Did she injure her arm? Likely. Or is she holding her arm because it's numb, because she's having a stroke? Maybe unlikely, but not out of the realm of possibility. That's where your interview skills really come to be important. Never assume anything. So if they're unresponsive, they're unable to give you that information, the burden is on you to try to get that information any way, shape you can. Preferably by the patient first asking their what's called chief complaint, but that's done more in the primary. If that can't be given because they're unresponsive or they're out of it, you get history from family or bystanders. What history can you get from the scene? Sometimes the only history you can get is by looking at the surrounding environment. Are they living in a very unkempt home circumstance? Is there tripwires all over the place? Is there fumes in the house? Is there unsanitary living conditions that could be causing their condition? Look at their medicine bottles. Are there bottles of insulin, cardiac pills, things that you'll learn about over time? And again, just because you see one patient doesn't necessarily mean you have one patient. So you got to kind of scope out the whole scene, and it's important to kind of assume that you might have more patients early on and call for resources and cancel them if they're not needed, than to underestimate what you have, need the resources, and now they're not available. Okay? Don't be afraid to cry wolf, so to speak. It's only going to protect you in the long run. So after you've all those factors, you've made sure the scene is safe. Okay, one more time. What was the question? I thought there was a question. Maybe I'm hearing an echo. So you assume the scene is safe. The scene has been secured. You know it's whether a trauma or a medical. Could you have both? Could you have a medical call that's actually a trauma call? Sure you can. For example, I had a call one time, came in as an altered mental status. The altered mental status, we got to the scene, it was a private house. The patient was an 88-year-old female who wasn't responding right. There were CFRs, firefighters on the scene. We come on the scene, we find her, we approach her. She's sitting in her chair upright. She's laid back, her head's kind of perched to the side. Just looking at her, I already knew what was going on. She was obviously having a stroke, but didn't have too much more information on that because it was a home health aide that was attending to her. There were no family members there. So, okay, stroke. Likely stroke. She was incontinent too. She had wet herself, unfortunately. So we go in, we intervene. Problem is now, as I'm getting a little more information, well, what happened? Well, the home attendant found her on the floor when she got here, and she called us. So she was on the floor under the table. So now what are we thinking about? Yeah, maybe she's having a medical issue. Maybe she's having a stroke. But what else do we have to worry about being that we found her on the floor? Does she have a head injury? Does she have a neck injury? Now, how does she get from the floor to the chair? Well, the firefighters, sorry to badmouth them, but they decided to pick her up and put her in the chair, which goes against everything they were taught in their CFR course. And I know that they were taught that in their CFR course because I taught CFR courses. So, yes, so it was an unfortunate situation. Hopefully nothing came of it. So what we thought was an initial medical call turned out to be a trauma call. So now we had to put a cervical collar on her. We had to maintain spinal integrity. Instead of being able to pick her up and put her on a stair chair and pulling her out of the house, we had to keep her flat and recumbent, and at that time on a straight longboard. And the captain of the fire department was a little oblivious to why we were doing that. And I tried to explain it to him, but I think it was more of a blow to his ego than anything else. But now, because of that situation, if we didn't know that she was initially on the floor, we wouldn't have known the potential traumatic complications she might have had as a result of the stroke. So when in doubt, always assume the worst, plan for the worst, and more appropriately, respond for the worst. So you make sure the scene is safe. You address whether it's medical, trauma, or both. See how many patients do you have, or how many potential patients do you have. You make sure you have all your appropriate body substance isolation. I mean, this picture right here looks appropriate for what I see. I mean, he's got gloves on, he's got goggles on, he's got a reflective vest. I don't see any shards of metal or broken glass, so it doesn't look like he necessarily needs a thick bunker gear, but okay, every situation may be different. You can't tell from a two-dimensional photo. Okay, and then, of course, what additional resources do we need? Do we need law enforcement? Do we need fire suppression? Do we need social work? Do we need ALS backup? Again, that all depends on how the scenario unfolds. So now that the scene size up is over and done with, let's actually tend to our patient, in which case we're going to do what's called a primary assessment, or the initial assessment. Terms are used differently every other day. And what we're talking about here in our EMT course holds true when you're talking about what happens in the emergency room, what happens in trauma centers. First thing they teach trauma surgeons is this ABC approach, focusing on the immediate life threats first, and then working your way down. So the primary assessment actually has a few different components, but it all takes priority on maintaining airway, breathing, circulation. Is their airway open and patent? Can they keep it open, or do you have to keep it open for them? Are they breathing? Are they breathing adequately? If not, how are you going to identify that and how are you going to address it? Circulation. Do they have a pulse? Do they have an adequate pulse, meaning they're perfusing properly? Are they losing blood? Now, we always go through this ABC format. It's not always ABC. Somebody mentioned CAB, could be BCA. It used to be very stringent on the linear approach to airway, breathing, circulation, airway, breathing, circulation. But as somebody mentioned before, if somebody is pumping out blood from an arterial bleed, are you going to take those steps to look, listen, and feel for their airway, to put an OPA in it while they're bleeding out? No. You're going to slap a tourniquet on that bleed, which we'll talk about when we talk about bleeding in shock, and you got to stop that bleeding immediately. Because if you don't, by the time you finish addressing that airway, they're not going to have any blood left. So really, what's the point of having an open airway if you can't get any oxygen, if you don't have any blood to get that oxygen into? So every situation is a little bit different. So like it says here, order of ABC depends on an initial impression of the patient. So airway, breathing, circulation, the patient has signs of life. If you've taken a CPR class in the past, you know that once you assess for their responsiveness, if there's no obvious signs of life, no pulse, then you got to basically start CPR and worry about airway and breathing afterwards if they appear lifeless. It's better to overtreat than to delay appropriate treatment. So what are the components of your primary assessment? There are 6 major components. The first is forming a general impression. And that's just the sense of everything that you gather as you're approaching that patient from the door. What do they look like? How are they positioned? Is there any potential for spinal injury? What is their chief complaint? Okay. How do they look to you? Do they look sick? Do they look hurt? Do they look well? Remember the general impression on that little girl in the parking lot as we were getting out of the ambulance, we had a little girl screaming and crying, but what do we know? We knew just by looking at her from a distance, she was alive, she had a mental status. We didn't have to ask her a chief complaint. We knew that there was, because of the mechanism of injury, there was need to take spinal precautions as well. But we knew a lot just from making that general impression. Then assessing the mental status. Really, the textbook talks about these laid out plans of assessing a mental status. Well, the best way, 90% of the time, to assess a patient's mental status is to say, hi, my name is Steve, I'm an EMT, how can I help you? And what have you just done? You've gotten their chief complaint. If they say, yeah, I'm having some chest pain for the last 20 minutes, just by them telling you that, what do you know? Well, one, you know they're alive. You know they have an open airway. You know they're breathing. You know they have a pulse. You've got a lot of information just by asking them one question. Now, the textbook goes into these other ways of assessing their mental status. Are they alert? Are they verbal? Are they breathing? Are they unresponsive? Are they painful responsive? Yeah, well, if they're telling you, hi, my name is Steve, yeah, I'm having some chest pain, they're alert. Simple as that. If you introduce yourself to them and they just kind of stare and kind of utter incomprehensible words like, what, kind of like you guys are doing when you're taking your exam, then their mental status is verbal. If you don't get any verbal response, but you kind of nudge them and they swat your hand away, or they kind of pull back when you pinch them. Don't watch where you pinch them. Everybody's got cameras these days. then they're considered to be responsive to painful stimuli. And at that point, if there's no response, it's complete unresponsive. They're unresponsive. Now, one pet peeve of mine is at that point asking me all these stupid questions like, who's the president? Do you know your name? I just told you my name. And again, a lot of ENT schools ask these stupid questions to assess mental status, which you're not really assessing their mental status, you're assessing their level of orientation, and that's not necessary during the primary assessment. It's just necessary to get a little bit of an idea of how their brain is perfusing. And again, if I introduce myself, I say, hi, I'm Stephen Needs, how can I help you? I fell down and banged up my ankle. It kind of sounds stupid to say, okay, what's your name? Do you know where you are? What day of the week it is? You know, some people don't even know the day of the week it is under normal circumstances. And people will look at you like, what the hell is this guy? It's telling me that you know how to read a note, but you don't know how to assess a patient. What would you ask? What would I ask? I'd say, what's wrong today? How can I help you? I think I broke my ankle. Do I know the person's mental status? Did they just respond to me in a meaningful way? Yeah, they're alert. I don't need to know that level of orientation right now. Maybe later on during the secondary, if I think there's some type of neurologic or altered mental status problem going on, some diabetic emergency. But right now, what's the purpose of the primary assessment? Glad you asked that question. What is the purpose of the primary assessment? The primary assessment is to identify and address any immediate life-threatening problems for that patient. Okay, so is it of the highest priority and urgency for that patient to know who the President of the United States is? Absolutely not. What's the airspeed velocity of another they swallow, whether it's African or European? Absolutely not. I don't think anybody's going to get that joke if they're under 40 years old. But anyway, so assessing mental status is very simple. And you'll have more practice when we get into groups on Saturday. Now, assess their. If they do have an altered mental status, are they automatically high priority? Well, that's a question I think you should answer by doing your reading. But absolutely, yes. Altered mental status means there's compromise to what organ? The brain. So yeah, I would call that a high priority, sure. But we haven't gotten to priority yet. So you form a general impression. You assess their mental status. Are they alert? Are they verbal? Are they responsive to painful stimuli? Or are they unresponsive? If they're alert, don't waste time with all these nonsensical questions. Go back to assessing the airway, breathing, circulation. Airway, again. Hi, yeah, I'm Steve. I've been having chest pain for the last 20 minutes. What do you know about my airway? I just said, hi, I'm Steve. It's fine, yes. Again, do you feel like there's a need to open your mouth and let me look in your mouth? Why? What are you looking for? Oh, I don't know. Maybe they got some gum in their mouth? Are you looking for a peritonsillar abscess? Are you looking for uvular deviation? No, you're not, because we're not teaching you that. Now, if they're unresponsive, if they're on the floor with no signs of life, do you want to take some steps to assess that airway? Do you want to look inside the mouth? Do you want to look, listen, feel? Do you want to see if there's chest rise? Do you want to listen if there's any respiratory? Absolutely. Do you want to consider suctioning if needed? Do you want to consider an OPA or an NPA if indicated? Absolutely. So really, it depends on how that patient, one step determines the next step. Assess their breathing. Okay. Medical patient, what's the best way to assess their breathing? Look at them. Are they breathing? Are they tugging their chins? Are they thrusting their chests out? Are they falling back, gasping for breath? Or are they speaking to you in a normal, comfortable manner? If it's a trauma patient, if it's a significant trauma patient, meaning a trauma patient with a significant mechanism of injury, then you got to investigate the breathing a little bit further. All right, you need to expose that chest. Male or female, doesn't matter. If they're a major trauma patient, you got to see if there's any holes in that chest or anything sticking out of that chest that could stop their breathing. You got to assess their adequacy of breathing. Now, again, if somebody's talking to you, telling you, yeah, I've been shot in the leg a couple of times, and maybe one hit me in the back, I don't know, Well, you know that they're breathing adequately right now. Okay. If they're not speaking to you, you got to take a few more steps. You got to look at their minute volume, their rate, and their volume. You got to do it quickly. So you got to get a quick sense. Usually when I say evaluate a patient's breathing, what do you want to know? You want to know, is it slow, medium, or fast? Slow, medium, or fast? It's medium, that's fine. It's too slow, too fast, you need to assess ventilations. If they're breathing medium, but their mental status is shot, they're unresponsive, or they're not alert, then they're going to need oxygen until proven otherwise. Then you go on to assess their circulation. Circulation is the first thing. Well, I shouldn't say the first thing. Like, do they have a pulse? Okay, well, if they're talking to you, if they're showing signs of life, they obviously have a pulse. Do they have a good pulse? Where would you want to assess a pulse in an unresponsive patient, whether it's trauma or medical? First answer should be, I'm asking Melody, I'm asking you, unresponsive, where would you assess first? The carotid, in the neck. And assuming that's there, okay, now you know that they have a pulse. Then you could go on to assess to see if they have a radial pulse. Would you go sticking your fingers in somebody's neck who's alert and talking to you and saying, I have some chest pain? No, that would probably be some bad form, in which case, how would you assess that person's pulse? You could simply just kneel down next to them, put your fingers on their radial pulse and see if it's there. Exactly. If radial pulse is not there, well, Mother Nature is pretty wise. It gave us two of mostly everything. Check the other wrist. Maybe this person has some vascular problem where he's not generating a pulse. Maybe he has a prosthetic arm. Maybe they're a dialysis patient that's had their radial artery rerouted. Check the other pulse. Now, if you don't feel a pulse in either arm, then you got to wonder, something's going on here. Look at the rest of the patient. What does their skin, color, temperature tell you? If they're cool, pale, and sweaty, no pulse in one arm isn't a threat, Jazeera? Maybe, maybe not. Again, if I'm a dialysis patient and I have a shunt in my arm, you're not going to feel a radial pulse in my left arm. You may feel a bounding radial pulse in my right arm because I just don't physically have a pulse there. Now, if I don't have a radial pulse in both arms, that's concerning. Look at the rest of the picture. What does their skin, color, temperature, moisture look like? If they're cool, pale, and sweaty, that's concerning. That's telling me they might be slipping into shock. We talked a little bit about shock during pathophysiology. And so then we have to think shock and treat for shock. Keep them warm, give them oxygen if we haven't already, lay them in a supine position. And then you got to think about, well, what if they are showing signs of shock? What's causing the shock? Is there any evidence of any external bleeding? Okay, are they bleeding from any areas of the body that we can stop? Are they bleeding internally? A little harder to evaluate, but it's something that we got to think about. And then finally, we got to determine the patient priority. Are they completely stable? What's a completely stable patient? A stable patient is usually someone that has a minor injury, who is calling because they need transport to the ER because they missed their clinic appointment, but no real complaint, as opposed to a high priority patient who's got things like chest pain, shortness of breath, multiple severe pain, uncontrolled bleeding, signs of shock, significant trauma. Those are really high priority patients. Okay, go back to the textbook and look at the list and the criteria. So going back and recapping now, going back to your general impression, a lot of the information you'll get just by looking at your patient. So you see somebody lying supine on the floor, elderly, doesn't look responsive. You're doing what's called a look test, feeling for environmental observations as well as your first look at the patient. Okay, what else do you see? I mean, this is a small view picture. What else do you see here? Is there any knocked over furniture? Is there any evidence of violence on the scene? Is there a gas stove that's been left on? We don't know. But you get an overall general sense of what's going on with that patient. Findings that indicate a possible critical patient is a patient that, again, is not responding to you very well. They're anxious. They have pale, sweaty skin that you could see. I mean, if you're going into a room that's about 68 degrees and this person's sweating profusely, that is a severe red flag that you have to address immediately, because people shouldn't be sweating profusely unless they're coming off the elliptical or something. Shouldn't be really sweating in a 68-degree room. Do you see any obvious trauma to the head, chest, abdomen? And then you got to address it immediately. Specific positions indicating distress. So, for example, being in a tripod position, where a patient is leaning forward, elbows on the knees, perching the head forward. We call it tripod. I don't know because they look like a tripod. But what a person's doing is when they're doing that is they're trying to align their airway to allow for maximum air exchange because something is inhibiting their breathing. Someone who has a clenched fist over their sternum is said to be in what's called a Levine position. That's a very telltale sign of a potential heart attack, or what we call myocardial infarction. And just a few to name. So again, if a patient appears lifeless on your general impression, have a low threshold for beginning CPR. Start with checking for responsiveness, obviously. Start with compressions. If they start doing compressions and a patient starts going, ow, 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 get off my chest, please. Well, then stop, okay? Then, all right, fine. Then we can go back and reevaluate. We can always reevaluate. But you don't want to waste time checking for a pulse if you think this person is unresponsive and appears lifeless. All right, better to start the compressions early and then reevaluate afterwards. Prepare that AED as soon as possible. And one of the pieces of equipment that you really need to have with you on every call is your AED. You go on scene, you go into somebody's house, calls comes in as a sick, cardiac, whatever, and then you find that person appearing lifeless on the floor, cardiac arrest, and now you send your partner back out to the ambulance to get the AED and then back. How much time has elapsed? How much time, how much muscle has died from the time that you discovered that patient on the floor to the time that AED came on the scene? As little as 1 minute means a 10% decrease in survival rate. So always have that AED with you and available for every single call. Again, another part of the general impression, this is very academic. Look, patient's age, sex, not sex position, meaning sex gender, and what position they're found in, supine, prone, slumped over. Are they making any noises, moaning, snoring, gurgling? We know snoring basically means what? Tongue blocking the airway, needs to be addressed with a manual maneuver and an adjunct. Gurgling really usually implies fluid in the airway, blood, vomit, whatever, needs to be suctioned. You know, some of the lovely stuff that we smell in our patient, fumes from maybe maybe not from external, but on their breath odor. They have a real pungent breath odor, could be a sign of alcohol intoxication, could also be a sign of diabetic emergency. Did they urinate or defecate all over themselves? Could be a sign of trauma to the bladder, to the spine, to the head, could be a sign of a seizure. Vomiting, decay, okay, are they dead? Is it obvious signs of death, decay, rigor mortis, dependent lividity. If you don't know what that stuff is, you should really look it on up. When approaching that patient, you want as best as you can try to elicit what's called a chief complaint. A chief complaint is the patient's description of why you were called. A chief complaint is not car crash. Chief complaint is my neck hurts because of the car crash. Or chief complaint is I'm having chest pain, not patient has a cardiac history. Now, it may be specific, like I have abdominal pain, in which case, you take it from that point on, or it may be vague. It's like, I just don't feel good, which drives me crazy. In which case, it's kind of incumbent upon you to try to tweak out what they mean by not feeling good. I'm under the weather. Well, can you describe that a little bit? That's your job as the medical clinician, is to really get that information. So once you get that chief complaint, again, are they alert? I don't agree with this slide. Document orientation to person, place, or time. You can do that later. If they're answering your questions in a meaningful way, they're alert. All right, knowing who they are, where they are, when they are, that's not going to make a difference in their priority right now. Later on down the line, that's a different story. Verbal, painful, and unresponsive. Okay, assessing, I'm being a little redundant here, but assessing airway, breathing, circulation doesn't necessarily have to be in the ABC order. Whatever you see that's potentially life-threatening first, address first, and then go to the next two. So if the airway's not open, open it. Either head tilt, chin lift if you're assured that there's no cervical spine trauma, or jaw thrust. Suction, if appropriate, and we talked about the techniques of suctioning, and insert an adjunct if tolerated. Preferably an OPA, but if they're gagging on OPA, then you have to measure and insert an NPA if it's available. Just remember the contraindications for both. And again, remember assessing the breathing. If somebody's awake, talking to you, appears comfortable, speaking in full sentences, that's your breathing evaluation right there. They're breathing adequately, they appear comfortable. Further assessment. If the patient is on the floor, if they're unresponsive, then you got to do a little bit more of a methodical assessment. You need to look, listen, feel, you need to assess, you need to palpate, you need to inspect for any obvious physical trauma. Kevin will demonstrate to you on Saturday. As far as circulation goes, not just enough to assess pulse, but you need to check skin, color, temperature, moisture, and look for any obvious external bleeding. When you're assessing the pulse, you really want to know if it's there. Okay, if it's not there, we're doing CPR. If it's unusually fast, that's good to notice too. So if you're checking a pulse and it sounds something like this, that's obviously a life-threatening condition. If you notice something like that, you should be calling for ALS backup immediately if you haven't already. If you hear something like this, assess that with the patient. If you have a patient with an abnormally slow pulse, but they're awake, talking to you, and happy as a clam, not really much intervention that needs to be made. If they're unresponsive and they have a pulse that's slow, call ALS backup, get your oxygen, and do your thing. And don't forget skin, color, temperature, moisture as well. It's very important. A lot of information can be given to you by understanding different presentations of the skin, what jaundice means, what cyanosis means, what ashen means, mottled means. You need to look all that up. Mottling is more peculiar in small children as a disruption of their circulatory status. Jaundice usually means problems with the liver or the biliary tract or sometimes pancreas. Hepatitis is an issue to consider as well. And so look at that. And when you think about what's a normal skin color, that's always a very interesting question, because I'm sure if we were all physically present in class, 20 different people would have 20 different shades of skin color, and it would all be normal. So how do you really judge what's normal in one person and not another? Well, one way is you can ask somebody who knows that person, does that skin color look normal to you? Or do they look pale? Do they look flushed? Because I don't know the person. I only met them 5 minutes ago. Ask the nearest relative or somebody that knows them. Another good place to assess skin color is not really the skin itself, but looking in the mucous membranes, inside the lips, the tongue, the pink parts of the eyes called the conjunctiva. These areas of the body should be pink in anybody, regardless of your ethnic background, whether you're African American, Asian, Celtic, whatever. If you have pale mucous membranes, that's a pretty significant sign that there may be shock going on, and then you need to treat it as such. And again, remember that the primary assessment is meant to treat immediate life-threatening problems. And that's the importance of drilling and understanding that, because you may come onto the scene where you have that individual who, a good picture somewhere, who maybe mangled their leg and twisted it into a pretzel, from a sporting event, and it can be very, very easy to get distracted and tunnel visioned into addressing that grotesque injury. But is a mangled tib fib likely to kill somebody? Probably not. Is the fact that they hit their head on the way down as with that injury, and now they're not breathing because there's an injury to the brainstem going to kill that patient? You bet. Is the fact that they're unconscious from so much pain and now their tongue is blocking the back of their throat, causing a blocked airway, is that likely to kill a patient? Absolutely. So again, you've got to remember that no matter how grotesque an injury is, if you go back to that formula of a primary assessment, general impression, airway, breathing, circulation, or in any one of those matters, deal with those first, block everything else out of your mind, and then you'll be successful every single time. And some of the other things just determine, as we mentioned before, okay, is this a medical patient or a trauma patient? If it's a medical patient, are they unresponsive or are they responsive? If they're unresponsive, you're going to really get most of your information from your physical exam. If they're responsive, then there's a list of questions, depending on what the emergency is, that you need to ask that patient, whether it's a cardiac patient, a diabetic patient, a seizure patient, a labor and delivery patient, and so on. And again, some things to think about, some food for thought. How might normal findings in a primary assessment differ for a child compared with an adult? Is a child likely to tell you, yes, I have pain in my left upper quadrant? No, they're not. Is a child likely to respond to injuries and illnesses the same as an adult? No, they're not. That's a question that'll be easier to answer once we've learned all the adult characteristics of emergencies, and then we go back and we talk about pediatrics and how they're quite different than adults. Okay, so once again, steps of the primary assessment involve starting off with the general impression. And there's no real definition of the general impression. There's certain things you look at, how the patient's presented, what they look like, the level of distress or level of comfort, any need for spinal precautions, any mitigating factors, any obvious signs of things that could kill them, any apparent life threats. That's, a Rottweiler tearing off the arm. Well, I guess you probably wouldn't go near that patient anyway, but something more serious, like an obvious airway compromise and something stuck in their throat. It's an obvious life threat. You got to take care of that before anything else. An arterial bleed, immediate life threat. You got to take care of that before anything else. Then you can assess the mental status. Alert, responsive, ABCs, and then priority for transport. If they're high priority, you're going to really just wrap them up really quickly, do a very quick secondary assessment, and then load and go. If they're low priority, that gives you a little more time to stick around and play and get more information. So as we wrap up this discussion, some of these questions you'll be answering in your discussion questions. Let's think about this. A middle-aged male is lying on the street after being hit by a car. Appears unresponsive as you approach. You notice that he's bleeding from a laceration on his forearm and making gurgling sounds from his airway. If you're alone, what factors do you consider in deciding what to do first and why? Think about that. Is the gash in the forearm the biggest thing to worry about? Check the airway first. But you know what? You're going to see that out there. You're going to see lame EMTs, or ambulance drivers with badges, sidetracked from what appears gross, what appears serious, but really isn't. You got a patient, and again, oh my God, I remember this one call. I got on the scene backing up this EMT crew. The patient's 70-year-old unresponsive female on the bed, and what's one EMT doing? And she's basically gurgling and snoring. What's one EMT doing? One EMT is taking a blood pressure. What's the other EMT doing? Sitting at the kitchen table, writing down all her demographic information, her name, date of birth, neither one of them are addressing the immediate problem. God, talk about making me want to flip. No oxygen on the patient, no airway maneuvers, no suction. That's what a bad EMT does. That's you don't know what to do, take another blood pressure. Don't know what to do, take another blood pressure. Do EMTs ever argue with each other over control? Yeah, sometimes it's a little bit of a dick measuring contest, especially if they're from different agencies. But again, from EMT to paramedic, who has the medical authority on the scene? Right. And then to paramedics, and it's a matter of, yeah. But ultimately, you just do what I say, and then all's good. All right, so that's patient assessment, scene size up, and primary assessment in a nutshell. Remember, scene size up involves what? It involves checking the scene for safety, and not just saying scene safety, literally assessing and checking and evaluating each and every time you approach a scene for safety and any potential safety hazards. And I just need a couple during this presentation. Checking the scene for safety, understanding whether it's a medical or a trauma, so the mechanism of injury or the nature of illness, looking at how many patients you have, how many you potentially have, your need for appropriate body substance isolation or personal protective equipment, whether it's goggles, gowns, gear, you name it, bulletproof vest, maybe. And then what kind of additional resources do you need? Do you need another crew just for a carry down? Do you need ALS for advanced medical care? Do you need law enforcement because there's some type of legal issue going on? Do you need fire suppression to help gain access to the patient? Do you need a supervisor on the scene because of some other type of administrative situation you're getting into? Then, only after all that's addressed, do you focus on that patient by doing a primary assessment, general impression. What does this patient look like? What sense do I get as I'm approaching that patient from the door? Level of responsiveness. Are they alert? Hi, my name is Steve. I have a little bit of chest pain. Can you take me to the hospital? Yeah, he's alert. I don't know. What? Verbal. Okay. Ow! Stop pinching me. Well, actually, if they say stop pinching me, they're not really painful, but you get the idea. Airway. Is it open? Will it stay open? What do you need to do to keep it open? Is there anything going on that you need to fix? Breathing. Are they breathing? Are they breathing adequately? If not, what can you do to assess their breathing? And what can you do to stop any impediment to breathing? If they have a hole in their chest from a bullet wound, you're going to need to seal up that hole. If they have a knife sticking in their chest, you're going to have to stabilize it in place. If they're only breathing 3 or 4 times a minute, you're going to need to take over their breathing for them. If they're just telling you, I'm short of breath, I can't catch my breath, and everything else is fine, you're going to need to give them oxygen and give them oxygen appropriately. And then later on in the secondary, we'll talk about more specific treatments depending on what type of respiratory emergency they have. It's an asthma attack, or there's certain medications we can assist them with. That's in the secondary. The circulation. Do they have a pulse? Are they showing signs of hypoperfusion? And if so, what do we do to correct that? The reason they're having signs of hypoperfusion is because they're bleeding from an artery. Well, we got to stop that bleeding, or else it's going to stop itself. And then ultimately, is this a high priority patient or a low priority patient? High priority, we got to really kind of wrap them up, get a good head to toe, and package appropriately and book. Or low priority, where we can kind of take in the scene, have a mind touch, and get a little more information that we may not have available if this patient decompensates on the way. All right, so with that, do we have any questions? It's a lot, and you're going to get a lot more on Wednesday, and then hopefully a lot of it will make sense on Saturday. Well, if you have any questions, you can always landslide Dan with it on Wednesday. Just, we're going to have a talk on pharmacology in a few weeks after the midterm, but generally we don't give pain medicines at the EMT level. Medic level is a different story. equipment do we need for Saturday, Waleed? So at this point, you should have a stethoscope, a blood pressure cuff, a ped light, and a watch with a seconds indication. Oh, Dan said none? I'll just have to reconfirm with him. Maybe he doesn't want you guys doing that this Saturday. Because, okay. Reconfirm with Danny. Okay, Wednesday, your vital signs secondary 6:10. At 6:10, you will have a quiz on scene size up and primary. Same as always, 20 minutes for the quiz. And if you read the chapters and you look at the notes and you look at the other PowerPoint slides and read the videos, look at the videos, you should be in good shape. All right, with that, I will say goodnight to you guys. No voices. All I hear is boing, boing, boing. You know, when I was growing up, we didn't have Xbox, we didn't have anything. You know what we had when I was a kid? What kind of video entertainment we had? We had something called Pong. Pong. It was 2 lines and a bouncing dot. And there was handball pong, and there was hockey pong, and you have about 4 different variations. And we thought this was the most advanced thing in the world. That's what it sounds like I'm listening to right now. You know what? I still have a remake of my old Atari, and I still think it's better than anything out there. All right, guys. Have a good night.